At the outset, would like to thank the organizing committee, Manoj sir and Purvi Chawla ma'am for this opportunity. I know it's a post-lunch session. I'll not make you people sleep more. I'll talk a little bit more on the clinical aspects of this important topic, what we call as the clinical utility of C-peptide in diabetes. My focus will be on a practical discussion, the utility of C-peptide mainly in the young onset diabetes. We all know that we use this biomarker, which is a surrogate marker of your insulin secretion. Mainly, most of you would have heard about in the evaluation of young onset diabetes. But again, you can extensively use it in other places, even in type 2, where you can be more precise in knowing the practice of precision diabetes. And also, with the increasing prevalence of obesity in the childhood and early onset type 2 diabetes, the older markers of age of onset, family history, that alone won't be enough. So again, adding on the C-peptide test would again add on to your benefit in the proper evaluation. So definitely C-peptide serves as a valuable biomarker of your endogenous insulin secretion, helping clinicians navigating the diagnostic challenges. So I'm just giving you an example, just to set the tone here. This is a 21-year-old male to have diabetes in the past 1 year on insulin, who came with osmotic symptoms, burning feet, and uncontrolled diabetes in spite of being on insulin. Initially presented with only ketosis, and A1C at diagnosis was 14%. He was labeled as type 1 diabetes considering the age of onset and the filament symptoms. He was discharged on a basal bolus regimen. Obviously, he was not compliant with the insulin, and he was not happy being put on insulin. He was there. Again, he had a repeat admission for the same problem. Again, when he was admitted, he did take, but he may take, instead of the 4 shots, he may take just a couple of shots of insulin and take a basal insulin. Again, he would stop. He would keep on doing this. His fasting was 204, post-meal was 354, A1C of 11.9. The C-peptide was done. It was a random C-peptide test, and it was 0.39 nanogram per ml. So whenever you look at the C-peptide, please look at whether it was a fasting C-peptide, whether it was stimulated, what kind of stimulation was it a random C-peptide? It's extremely important. You should look into the corresponding glucose number. That's also important. I'll come to that later. The GAT65 was negative. There was a family history of diabetes, but not the young onset. The onset was above 40 years. No complication at baseline. If you look at the anthropometry there, lean BMI 19.5, but you can understand 11% for uncontrolled. So obviously you would have some weight loss there. No signs of insulin resistance. Ultrasound abdomen pelvis also was done to rule out pancreatic diabetes. He was continued on a basal bolus regimen, was asked to be compliant with the same. Do people find any difference here? Again, do you feel at this point, before I proceed further, was there any mistake in the workup of the young onset? Was few tests could have been done in a better way? Because you see a low C-peptide, GAD negative, is it a type 1B? Yes, ma'am.
So sugars were very high, and
Right.
the time C-peptide was not the right time to do it.
Exactly, ma'am. That's your hit.
Cut down the sugar
Exactly.
levels, then would have done.
Exactly. So that's the first thing. So let's not. I think we all would have done this mistake during our residency. In our initial days, probably you've seen your high young onset, you would directly order the test. We should not do that. That's what ma'am rightly pointed out. When your glucose levels are high, please avoid doing C-peptide test in the view of glucotoxicity, because it can be falsely low, and entirely it can lead to a misdiagnosis. So I'll just give you what is this connecting peptide or the C-peptide. This is a 31 amino acid, a linear peptide, which is secreted along with your the insulin from the proinsulin. It is released equimolar with insulin, but with a longer half-life. Does not undergo the hepatic first pass metabolism, unlike your insulin. That's the reason why at the periphery you are able to measure this much better compared to insulin. It's definitely a better surrogate marker than the endogenous insulin secretion, making it a clinical for your clinical assessment. Obviously, as I said, why don't we prefer insulin over C-peptide is because insulin has a shorter half-life, and the hepatic clearance is much quicker there, and your exogenous insulin also can interfere with your measurement. Obviously, you can do the serum samples, you can do the urinary C-peptide to creatinine ratio, but again, there are few challenges there. And again, when you talk about the assays, we'll talk about that radioimmunoassays and the modern immunoassay. But this is very important. Many times, a type 1 patient on insulin, sometimes you would see a test of fasting insulin being done. That's again a very false marker, because your fasting insulin can be again falsely elevated because of the exogenous insulin. So, and there can be some cross reactivity. So always prefer this test. But again, when you do it, the collection, the assay, these are some of the very important things. So how do you do it? First thing is obviously maintain some amount of euglycemia before you do it. Don't jump the gun by doing right away order this test. You can do your autoantibodies, but whatever the diabetes be, your goal should be first to control your glucose level. That's the cornerstone. Preferably you have your fasting C-peptide, you have a non-fasting C-peptide or a random C-peptide. Stimulated C-peptide, that is very important, the stimulated C-peptide, then you have the urinary C-peptide. But among this, if you ask me cost constraint, just one test I need to do it, you'd go for a stimulated C-peptide. Stimulated C-peptide is kind of after your meal, how much your beta cell can produce insulin. That could be a mixed meal challenge, it could be a after a carbohydrate meal. Research setting, we do the glucagon stimulation, arginine stimulations, you would have heard of it, but the most standard is after a standard carbohydrate meal. So obviously when you talk about the assays, there are, compared to the radioimmunoassays, you have the CME and the fluoroimmunosense, which has bring down the assay cost and also improved the detection limits. But again, you should be well aware of which lab, which method they are doing. But please pay attention to this last one. It is generally reported in picomole per ml, or most of the labs, standard labs in our country report in nanogram per ml. This conversion is very important because in our institute, we follow the picomole per ml. Sometimes a person would have done it in ng per ml. Picomole is much lower. So when you see it in picomole, you need to ideally divide it by 0.3 or the other way around. Or you see it in ng per ml, you get it in picomole, you need to multiply into 3 to get it in ng. Sometimes what happens, you would label it, you would see in ng, a person would do, he'll cross-check in one more lab. So always look at this conversion. This conversion is very important when you're interpreting the C-peptide result, because again, I'll come to the normal assays and what is the limitations later. So what are the factors which can affect your C-peptide levels? As I said, the most important is it must be avoided in the setting of a severe hyperglycemia because of the glucotoxicity, and it can lead to misdiagnosis. Please interpret your C-peptide levels with the corresponding glucose values. If you have a fasting and a post meal, and then you look at the C-peptide values, you get the subtle markers. You will know whether this person is a SID form of type 2 or is it type 1. Somebody may have a very good basal level, but the stimulated C-peptide may not be adequate. These are your subtle markers. So always when you interpret with your corresponding glucose level, it is extremely useful. Obviously, renal impairment or CKD can also cause falsely elevated levels due to decreased renal clearance. And obviously in type 2 diabetes, you would have heard of this cluster, iroid subtype. They tend to have, mainly because of the insulin resistance, they have a kind of an elevated C-peptide. And obviously it's very important to combine this with the clinical context as well as your antibody testing. Again, you have the spectrum. I think most of you are already aware of it. When you get a type 1 with a low C-peptide, autoantibodies positive is a classical type 1. You can have an autoantibody negative and a low C-peptide, what you call as a type 1B diabetes. Then you have something called as a ketosis prone diabetes, one of my favorite area where I've done few studies in that, and you would see that in acute stage there is low C-peptide, then the beta cell recovers. That's the other variety. Then again you have the LADA, where you have the C-peptide is positive, but the autoantibody is also positive. They'll be in the honeymoon phase and they can progress. So these are the different, how in each types you see a different types. Type 1, as I said, you can have generally the honeymoon phase, you can have some low detectable C-peptide levels. Type 2 is a spectrum. A severe insulin deficient subtype will have a very low C-peptide, whereas an iroid subtype will have a little elevated subtype. FCPD or a fibrocalculous pancreatic diabetes, again you can have a very lower again you have a spectrum in FCPD. MODI is generally preserved, the C-peptide levels are well preserved. And KPD, as I mentioned already, you may have a low and again a high C-peptide levels. So coming back to this case, so he came to us, so the same case, low C-peptide labeled as type 1. He came to us for a second opinion, and obviously after detailed history and biochemical parameters, he was obviously continued on insulin. A basal bolus regimen, aspart 8, 8 and 6 and degludec 12 at bedtime. And sometimes CGM, people who are used to CGM, it's like your ECG. You keep looking at the CGM, you would understand what kind of, looking at the glycemic variability, you get a kind of an idea. A classical type 1 with a very low C-peptide will have a lot of GVs, high troughs and peaks and troughs. So this person kind of at the second week, once the glucotoxicity settled down, the CGM graphs were also much better. I forgot to put the CGM graph here. But after 6 weeks, once the euglycemia was achieved with stable glucose values, the fasting and stimulated was repeated. And you see the result here. The fasting C-peptide is 0.77 picomole per ml. Those are your reference. Again, these references are in picomole. Stimulated was 2.48. Please multiply into 3 when you convert into ng per ml. So the fasting would be almost 3.77 and in ng would be more than 6 plus ng per ml. So obviously this person has quite a good amount of C-peptide. Obviously at this point I didn't jump the gun. GAD was negative. his basal insulin was continued, but a low dose sulfonylurea. Obviously, you talk about monogenic, you thought of, in a resource poor setting, if we do the monogenic testing, but again, clinically you would see by adding a low dose sulfonylurea, but don't stop the insulin. The basal insulin was continued. 30 milligram of glycoside BD with sitagliptin was added. After 8 weeks, his A1C actually came down to 6.6. Insulin was stopped as his requirement had come down. Once you added gliptin, it started coming down. OADs was continued. But having said that, in a resource poor setting where you can't do all the triple antibodies, you can still do a serial monitoring of C-peptide to understand the progression. So maybe every 6 months, 9 months, or yearly once. And again, if cost is a problem, you can still do a stimulated C-peptide to understand the progression. From baseline, it is going up, more behaving like a type 2 or a MODY. From baseline, it's declining. He could be LADA or in a honeymoon phase. These are the clinical judgments you need to make in some of the patients. So we repeated this C-peptide after 9 months to see the progression. The levels still remain quite good, 2.7 picomole or 8.1 ng per ml. So it's almost behaving like a maturity onset diabetes, probably. We have not done the genetic testing, and we published this paper last year, where in our population, where you cannot do all the autoantibodies, the serial monitoring of C-peptide definitely helps in your prognosis, whereas in your diagnosis, as well as to understand what type of diabetes it is. That also will aid your treatment rather than doing the classical way of doing all the autoantibodies. So obviously, to summarize everything, this C-peptide testing definitely helps in the diagnostic value, in understanding the evaluation of young onset diabetes or also the subclassification of your type 2. It also is a prognostic marker. The residual C-peptide is associated with better glycemic control. Even those type 1 who have some amount of beta cell reserve generally have a lesser glycemic variability as compared to somebody with a complete nil C-peptide. You would see some type 1s, the levels will be all over the place, and then you have some who would beautifully maintain with a very minimal insulin requirement. So a little bit of marker is extremely important. And obviously there are trials. Lower levels are associated with increased microvascular complications. So coming to the last slide, key takeaways and the future directions. Definitely the C-peptide is a robust surrogate marker for your endogenous insulin secretion, excellent and essential for your guiding your therapy decision, improves accuracy in diabetes classification, serial monitoring aids in personalized management. Most important, as mentioned by ma'am, the testing should be avoided when the glucose levels are high. Please underline this, because it can falsely give you low values and can lead to an entire lead of misdiagnosis. Again, in future directions, if you see, global standardization of the assays are very important and also to establish a universal reference range. Integration with the genetic and the antibody testing will definitely help, mainly in the workup of young onset diabetes. And obviously, this can be used as a surrogate marker in your clinical trials. Thank you.